Dr. Rushil, because what Apurva has shown is only macular disease. Are you treating only ARMDs in your with?
Sir, you are not my opponent.
So I think she has presented very well, but she has just shown us the good. Now I'll show the bad and the ugly and the real world, what we see in the real world in the high volume clinics. Okay. So thank you all for giving me this opportunity. So like she said, like it's a very, OCTA is a very quick non-invasive method to detect various vascular complexes in the retina. But to detect that vascular complex, we go through multiple problems, such as we have to rule out multiple artifacts, whether we need to segment these lesions to get a better view, or most importantly, what we are seeing, is that an actual complex, is that a pathology, or is that an artifact? So the reproducibility of these images is a big question. So I'll come to a few artifacts which we see in the recent publications. It has shown that up to 100% of the cases will have at least one artifact, which can be either patient related, software related, or operator related. So the most common artifacts which we see are, one is the loss of contrast. This image in which there was a vitreous opacity in the center, which can erroneously be interpreted as a flow void area. Other artifacts which we commonly see are the projection artifacts, in which the superficial layers are superimposed on the deeper layers, like in this image on the left. On the right, which we see on the top of the PED, there is a neovascular, there is a deep vascular complex which is superimposed on the PED, and it can be erroneously interpreted as a neovascular complex, and we may end up treating this patient. The most troublesome artifact by far is the segmentation artifact, which ironically happens only in diseased eyes or in highly myopic eyes. Like in this eye with the posterior staphyloma, the segmentation is all over the place, and in this eye with the PFT, the inner retinal layers are collapsed, and again the segmentation is all over the place. So various imaging processing softwares and algorithms have been made in literature, but none of them are standardized at present, and they may themselves be have artifacts such as vessel doubling, so it makes it very difficult to read the images. Another limitation is the field of view, which although newer machines are coming up with a wider field of views, they are not of much use clinically. But right now what we have is a very limited field of view, and the wider field of views are associated with loss of image quality, which can make it difficult to interpret. So again, I'll just touch upon the two most common indications in our routine clinics. One is diabetic retinopathy. So OCTA does not give us any information on leak. So it is very difficult to make out the leaking microaneurysms, and due to the limited field of view, we are not able to make out the peripheral neovascularizations. Again, segmentation is a big problem in edematous macula, which can be found in up to 50% of patients of PDR, which will lead to segmentation defects and erroneous readings. And our treatment is still guided by structural OCT. In neovascular AMD, I grant you that you will get very, very beautiful images, but what to do with the images after you treat, it becomes very difficult to, there is no standardized definition of an active and an inactive CNVMs, so it will become very difficult for us to know when to treat and when to stop the treatment. Also, again, we will have significant segmentation and projection artifacts. Certain CNVMs which are deeper, intra-PAD CNVMs or sub-RP CNVMs, you can tend to miss unless you segment manually, which can be a very time-consuming process. So we should be, all the literature you showed, we should be very cautious in applying that literature, because there is a current lack of standardized interpretation protocol, nomenclature, and image quality indicators. So various efforts are being made to standardize the various definitions and protocols. This was an article by Spade et al. In 2018, where he bugged us all up that we should get on it and interpret and take out some standardized protocols. 5 years later, we are at the same place. There is still no standardization, and therefore we cannot. There is no reproducibility, and there is no inter-user agreement. So to conclude, is OCTA worth adding to your practice, considering its high cost, limited limited clinical utility, lack of standardization and inter-user agreement. At present, I would say it appears to be more of a solution looking for a problem rather than being an actual solution to a problem. So maybe someday it will be required in clinical practice, but not today.
Rebuttal from you to Rushil.
Whatever points he has made are 2 to 3 years old.
This
Okay.
was an article in 2022.
No, but one article you can't show and say this
No,
is
this
the
was
most.
total.
Okay, no problem.
Okay, fine.
But yeah, so the projection artifacts, segmentation problems, these are 2-3 years old questions. They have all been sufficiently answered by projection resolving and segmentation, which takes only 10 seconds if you make a section of 15-20 microns from the ILM to the Brooks membrane. So I think apart from having any machine, you also need a person behind the machine who can interpret images. So if you give some high-end imaging machine to somebody who is not interested in imaging, they will not find anything on angiography, invasive or non-invasive.
Very true. The person behind is important, and you have to see in fast, or you have to move the sections.
Yes.
I'll ask Deepak and then Neeraj to give their comments whether OCTA is mandatory for the practice or not. And then we'll take one person from the audience. I'll ask Dr. Guru Prasad to comment after that. No, we'll have an independent opinion.
Every new technology has its pros and cons. Octa has been there for quite some time now, and we are learning on it. Maybe over a few years, we will learn more. The only problem is the availability remains an issue. It's not available at our center to be precise, and then again, the cost-benefit is a ratio is a thing. So, to be very frank, I don't have much experience with Octa.
I will add to this, Dr. Abuwa, you are right, and like Vininder said, that you have shown only the central lesions, AMD lesions only. So there are other indications of angiography also. So I would say that Octa is an add-on at present, and as he has also said,
with my bare eyes also.
so you can see that, but because there are certain other problems in the retina also that may need an angiography, the leakages and all those things, the effect of treatment of laser, so that all that may not be very well picked up at present. So maybe future is there, but definitely I think these are both supplement to each other. If you have both technologies, that is better than having either one of them. So
Can I speak
any
once?
comments?
Yeah.
The best application of Octa is in pachychoroid disease with CNVM. You cannot diagnose CNVM in such cases with OCT where you think it's a CSR, and also FFA and ICG, as she showed, just shows a stippled hyperfluorescence. You do not get the CNVM leak. The moment you do Octa, that amazing vascular network is crystal clear, and you don't need to think anymore. You have to inject anti-VEGFs there. So this is the best possible application of Octa at present. And many a times when we pick up a CNVM on OCT, instead of doing an FFA, most of us do a baseline FFA, used to do a baseline FFA. So instead of doing a baseline FFA, if you have a Octa, you can take a Octa image, show the CNVM network and start the treatment without injecting the dye. But yeah, it's a very costly machine, so it needs a few more years, lowering of costs, and then it is a technology which will continue.
We will take, is it mandatory for your practice, and then Dr. Dr. Guru sir. And then one mic to Dr. Dinesh Chalwar, please. Here.
So I think both made their points very well. These debates, I tell you, are to get the best out of each speaker, to get the pros and cons of each technique that they're talking about. It is not about fighting or arguing. So I think we have to collate the two and take it is up to the audience to extract the best out of the argument that is going on, or the debate that is going on, so-called debate, which is not really a debate according to me. It is a scientific knowledge outpouring which we have to get the gist out of it. So, but then, yes, there are certain disadvantages of Octa in terms of the field of capturing that we have. It's just about 6 by 6. Even if you stitch, so-called stitching that is described by the manufacturers, I think it is not so easy. The posterior pole, yes, for ARMD, it's a wonderful tool. Angiography has its own plus points in the peripheral diseases. So that way, I think we have to, get the best out of all these.
Dr. Dinesh, please. Now with wider field octas are available with 12 by 12 and 16 by 16. I think with 12 by 12 montage which will come, I think it will become more useful.
If we stuck to what we have, then we would be still in the Stone Age. We would be using the wheel which was made of stone and traveling by bullock cart. The fact is that every new thing that comes needs refinement, and refinements are going on in Octa to a level that there are certain subtle diseases, as Arindam just mentioned, where we can actually say this does a better job. We also have a situation which I think you were trying to mention. Wide field Octa can pick up neovascularization, areas of capillary non-perfusion in cases of diabetic retinopathy. So so it's not something confined to the macula. We are moving from the center to the periphery. Yes, it's an expensive machine like any others. There was a time when there were hardly any hotels. We could not have afforded this kind of conference. There was a time when the conferences were done in Maidans. Today there are so many options, so the cost comes down, and we expect the cost will come down. But we need a few early adopters. The early adopters are those who will be at that cutting edge to pick out, and they will also be wrong many times. They will find what they find will turn out to be wrong with the passage of time, but they will also find a lot of new things. And today OCTA is something which is mandatory if you are in a teaching institution which wants to stay on a cutting edge. If you want to do a high volume surgery where you just want to deliver mass cheap surgery, you can do with OCTA.
Is it still a research tool? I think.
I didn't say it's a research tool. I said if you're at the cutting edge, then you want to see how to refine its use. But if you're not at that cutting edge, because this takes time, yes. As Avninder was saying, manual cutting, manual segmentation is not so simple. That she was trying to put it a little less than it is. It is, if you want to do a proper manual segmentation, she needs to do it, not her technician. So there's a difference, and she is very busy.
Actually, OCT, many a times we detect lesions once we sit on the machine and we do a manual in-fast segmentation. And what the machine shows at ILM, that does not give any information. Actually, you have to go to what Apurva shows. Either you have to do a video in fast imaging, or you have to manually change the area. You will get a lot of information. And in those situations, you are also able to get away with projection artifacts.
Thank you.